Hi, good morning everybody. I welcome all the students to the class of pathology. And that last time we were dealing with the topic liver. In that we already saw about the chronic liver diseases. So continuing that particular class, myself Dr. Rajesh Patil welcome you all for liver function test class. That's the heading for today's. So today we'll be dealing with this liver function tests. So important. This is more of a biochemical class, biochemistry class rather than pathology class. But this is a main. It could be asked not as a main question, but 5 marks essay type question can be easily asked on this particular topic, and important when it comes to viva. So invariably in clinical pathology, a question invariably is asked by the examiners on liver function tests. So we'll be dealing with this normal liver structure that I'll not deal much because we already have dealt with this particular normal liver structure. The liver function test introductions, classification, the indications and the interpretations and few limitations in these particular liver function tests. So in clinical practice, most of the physicians, surgeons, gynecologists usually write this test, liver function test, wherein they suspect any abnormality or any diseases or any disease related to the liver organ. Okay, so this is the normal anatomy and the histology which we already have dealt with during the class of cirrhosis. We'll continue with this particular thing, the hexagonal lobules and the arrangement, double arrangement, cords arrangement of the hepatocytes. We'll skip these few slides of normal histology. Coming to functions of liver, which we also have gone through. So the metabolic function, which is there is a key, this is a key organ principal site where carbohydrates, lipids and proteins take place. Ammonia is converted to urea. These are important few facts wherein the tests comes into play in determination of these biochemical substances. Cholesterol is synthesized and catabolized to form bile acids and bile salts. See cholesterol. So when it comes to conversion, presence of serum cholesterol levels also is an indicator. So indirectly this means that esterification of cholesterol, okay, absorbed other monosaccharides to glucose. So fructose is converted to glucose, all these basic functions. So assays of these biochemical substances is of utmost importance. So basically the secretory function, formation, secretion of bile in the intestine, excretory functions, the synthetic function, that is synthesis of proteins like albumin, alpha and beta globulin, synthesis of fibrinogen, synthesis of clotting factors. So all this you should be aware of. Basically detoxification function, detoxifies drugs, hormones, converts to less toxic substance for excretion. Storage function, in various storage disorder there could be hepatomegaly like glycogen, vitamin B12 storage, important vital vitamins, and the miscellaneous functions. So in blood formation when it's in embryo, that is extramedullary hematopoiesis can also takes place here in the liver in earlier years of life. Indications. So this could be even the 3 marks question. Indications of liver function tests. Differential diagnosis of different types of jaundice to assess the severity of liver damage in known liver diseases, to follow the trend of the disease, to diagnose the presence of latent liver disease such as in differential diagnosis of ascites, hematemesis. So this commonly ascites, hematemesis is an association of a disease of cirrhotic liver. So to diagnose or rule out such an ailment, you have to do these liver function tests. To screen the suspected cases during outbreak of infective hepatitis, outbreak could be hepatitis C, hepatitis A, the outbreak of this particular hepatitis, the screening tests. To screen the persons exposed to potential hepatotoxic materials in industry. To screen the persons exposed to hepatotoxic drugs, all the screening tests. And to follow the response to treatment. So definition. Liver function tests are tests of derangements of individual functions of the liver. So any derangement in the normal function of this particular liver, so to assess that, that is the liver function tests. How do you classify them? Basically, tests based on abnormalities of the pigment metabolism, serum bilirubin, VDDA reaction. So we'll deal all this in the later slides. Urine and fecal bilirubin, urine and fecal urobilinogen, bile acids, bile salts. So tests based on liver part in carbohydrate metabolism, like GTT, glucose tolerance test, galactose tolerance tests. So all these are the part of LFTs. Tests based on changes in plasma proteins, estimation of total plasma proteins, albumin and globulin, and determination of AG ratio, determination of plasma fibrinogen, tests based on abnormalities of the lipids, determination of serum cholesterol and ester cholesterol and their ratio. So these usually are the LFT proper, wherein you do all these assays: plasma proteins, albumin, globulin, AG ratio. Test based on detoxification function of liver, hippuric acid synthesis tests. Test based on excretory function, that is bromsulfathiline test, rose bengal test, indocyanine green test. So at least you should be aware of the names, important ones here for excretory function. Formation of prothrombin by liver, very vital one. The PT, prothrombin time, important one. Test based on amino acid catabolism, determination of blood ammonia, determination of glutamine in CSF. So test based on drug metabolism, monoethyl glycine xylidine, MEGX test, antipyrine breath test, determination of serum enzyme activity, and immunological test, very important ones, the antibodies to hepatitis B and other hepatitis viruses. So we'll deal with that. And other diagnostic tests could be in the form of ultrasonography and percutaneous liver biopsy. The biopsy always the gold standard for a diagnosis in correlation with biochemistry for a diagnosis of any kind of liver disease or the liver ailments. So interpretation of LFTs. Tests based on abnormalities of the pigment metabolism. We'll start off with, that is the bilirubin. So bilirubin is the end product of heme degradation. So bilirubin pigment can be detected in serum, feces and urine. So commonest test being written by the physician. So the normal values, as you all know, just to brush you up with the basics, total bilirubin 0.2 to 1.2, direct up to 0.2, indirect up to 0.8 milligrams percentage. So this is again the normal bilirubin metabolism here being shown in the schematic diagram here. So the normal bilirubin products from heme is derived primarily from the breakdown of senescent circulating erythrocytes. The second step, extrahepatic bilirubin, is bound to serum albumin and delivered to the liver. Hepatocellular uptake and glucuronidation in the endoplasmic reticulum. Hepatocellular uptake, glucuronidation in the endoplasmic reticulum. Then it generates bilirubin monoglucuronides and diglucuronides, which are water soluble and readily excreted into bile. Gut bacteria deconjugate the bilirubin and degrade it to colorless urobilinogens. The urobilinogens and the residue of intact pigments are excreted in the feces with some reabsorption and excretion into urine. So this was a brief with the schematic diagram here, the normal bilirubin metabolism and its elimination. Okay, so this diagram is important, that you have to draw how these substances are derived from the senescent RBCs and ultimately forming the urobilinogens. So method of serum bilirubin estimations. So Vandenberg reaction there, direct spectroscopic method, DMSO method, it's not so important here. The Vandenberg reaction principle is based on the formation of reddish purple pigment, that is bilirubin. It has two parts, direct and indirect. In direct reaction, there is immediate color formation, indicate presence of conjugated bilirubin. So all this Vandenberg reaction in first year biochemistry, you have studied it already to brush you up. In indirect reaction, color is formed after addition of methanol that indicate presence of unconjugated bilirubin. In hemolytic jaundice, there is increase in unconjugated bilirubin, hence indirect reaction is obtained. Occasionally it may give delayed direct reaction. So this is a feature in case of hemolytic jaundice. In obstructive jaundice, conjugated bilirubin is increased, hence an immediate reaction, that is direct, is obtained. In hepatocellular jaundice, either or both may be present. So limitations of Vandenberg reactions. An immediate direct reaction is obtained whether the obstruction is intrahepatic or extrahepatic. So depending upon that. Thus it does not differentiate between an infectious hepatitis or toxic jaundice and post-hepatitis or obstructive jaundice. So there are few limitations of this Vandenberg reaction. Estimation of bilirubin in urine and feces. Bilirubinuria does not occur in normal subjects, nor is unconjugated bilirubin excreted in urine. Bilirubinuria occurs only when there is a raised level of conjugated bilirubin. So when there is raised level of conjugated bilirubin, there is excretion. So following tests are done for detection of bilirubin in urine. What are those important ones? The Faucet's test, foam test, iodine test, Galen's layer test, reagent strip test. Principle: most of these tests depend on the oxidation of bilirubin to differently colored compounds such as biliverdin, that is green, and bilicyanine, that is blue. Now what's the interpretation here? Bilirubin is found in the urine in obstructive jaundice due to various causes and also in cholestasis. So bilirubin is not present in urine in most cases of hemolytic jaundice. Bilirubin is always accompanied with direct Vandenberg reaction. So this is how you interpret this particular reaction, the presence of bilirubin. So bilirubin in the urine may be detected even before clinical jaundice is noted. So important clue there. So estimation of bilirubin can also be done in the feces. So in feces, excretion of bilirubin is assessed by inspection of the stool. So this you should be aware of. So bilirubin is not normally present in feces since bacteria in the intestine reduce it to urobilinogen. So sometimes it is found in feces of very young infants if bacterial flora in the gut is not developed. So it is regularly found in feces of patients who are being treated with gut sterilizing antibiotics such as neomycin. So clay colored stools due to absence of fecal excretion of the pigment indicates obstructive jaundice. This is a Viva question. Clay colored stools, where? Obstructive jaundice. So this is estimation of urinary and fecal urobilinogen here. So we will not deal much about this urinary excretion of this particular urobilinogen here. So you should be aware of this. This is important point that you can write in your answer. So the interpretation: fecal urobilinogen is increased in hemolytic jaundice in which dark colored feces are passed. Fecal urobilinogen is decreased or absent in obstructive jaundice in which clay colored feces are passed. A complete absence of fecal urobilinogen is strongly suggestive of malignancy malignant obstruction. So this is an indication of malignant obstruction. So in cases of especially the gallstones, okay, wherein there is intermittent obstruction, so that could cause obstructive jaundice there. So urine urobilinogen, so average is 0.64 milligrams. So this is for 24 hours, 4 milligrams. Methods of estimation of urine urobilinogen: Ehrlich's test, reagent strip test. Interpretation: Presence of bilirubin in the urine without urobilinogen is strongly suggestive of obstructive jaundice. Either could be intrahepatic or post-hepatic. So the increased urobilinogen in the urine and absence of bilirubin in urine are strongly suggestive of hemolytic jaundice. So increased urinary urobilinogen may be seen in damage to the hepatic parenchyma. So the bile salts in urine, the assessment of this, the important one, commonly done test in any lab. You want a technician run lab or you want a department side labs. So commonly done tests, easily done tests. Bile salts excreted in urine are cholic acid and quinodeoxycholic acid. Methods of estimation: Hayes sulfur test, high performance liquid chromatography. So in Hayes sulfur test, sulfur powder is sprinkled over the urine layer. If bile salts are present, the sulfur powder sinks. Okay. Interpretation: bile salts are present in urine in case of obstructive jaundice. So when you sprinkle this sulfur powder, when this particular powder completely sinks, the bile salts are present. So test based on carbohydrate metabolism. So even this is an important function of the liver in carbohydrate metabolism. Hence the test based on it. Principle: the tests are based on tolerance to various sugars, as liver is involved in removal of these sugars by glycogenesis or in conversion of other monosaccharides to glucose. The glucose tolerance test, the interpretation. So this is not of much value in liver disease, okay, but still is part of function test. So in most of the liver diseases, GTT is diminished. You should be aware of this particular fact here. So galactose tolerance test. Normal liver is able to convert galactose into glucose. This function is impaired in intrahepatic diseases. So amount of blood galactose and the quantity of this galactose, there is a double repetition of that particular word. The amount of blood galactose is excessive in the urine. Advantages: it is used primarily to detect liver cell injury. It can be performed in presence of jaundice. So basically this is another test here. So this is a part of the liver function test, not a very important one, but you should be aware of that. So the oral galactose tolerance tests and all this, okay. So this is part of function tests. So the IV galactose performed after night fast, IV galactose equivalent to 0.5 grams is given as 50% solution. Blood samples are collected at half an hour interval for 2 hours. Interpretation: normally at the end of 2 hours, blood levels of galactose is 0 to 10 milligram percentage. In parenchymatous diseases, it is up to 20 milligram percentage at the end of 2 hours. Now, test based on changes in plasma proteins. So, important one here. So, the estimation of plasma proteins, albumin and globulin, and determination of the AG ratio, albumin globulin ratio. Determination of plasma fibrinogen. The methods of estimations, again, the biuret method, electrophoresis. So the electrophoresis of serum proteins gives an accurate estimation of different proteins fractions. So you should be aware of this. This could be asked even in as a 3 marks or even in the Viva. The common values you should know. The serum total protein 6 to 8 grams per deciliter. Serum albumin 3.5 to 5. Globulins 2.5 to 3. Then gamma globulins 0.5 to 1.5. So ratio, AG ratio 1.5 to 3.1. So the formation of these albumin globulins in the liver. Interpretation: in case of infective hepatitis, in early stages rise in beta globulins, in late stages gamma globulins show the rise. In obstructive jaundice, it is normal unless obstructive jaundice is associated with accompanying liver damage. In advanced parenchymal liver disease and in cirrhosis of liver, albumin is grossly decreased and the globulins are often increased. AG ratio is reversed. Increase in gamma globulin and beta globulins is seen. So estimation of the plasma fibrinogen levels. Important one again, this one. The fibrinogen is formed in the liver and likely to be affected if considerable liver damage is present. The normal value 200 to 400 milligram percentage. What's the interpretation? Values below 100 milligram percentage suggest severe parenchymal liver disease. So this is basically its interpretation. Examples: acute could be acute hepatic necrosis, it could be poisoning due to CCl4 in advanced stages of even liver cirrhosis. Now, tests based on abnormalities of the lipid, determination of serum cholesterol and ester cholesterol and their ratios. So the normal total blood cholesterol ranges from 150 to 250 milligram. So this test is not only a part of lipid profile but also a part of liver profile, that is liver function tests. Interpretation: in obstructive jaundice, increase in total blood cholesterol is very common. So the parenchymatous liver diseases, there is decrease in total cholesterol. The degree of reduction roughly parallels the degree of liver damage. See this. So the estimation of cholesterol is very much proportional to the extent of the liver damage here. So the degree of reduction of cholesterol roughly parallels the degree of liver damage. Severe acute hepatic necrosis, the total serum cholesterol is below 100 milligram per deciliter. So serum cholesterol level goes on falling here. Tests based on detoxification function, that is hippuric acid synthesis test. So it is best known test for the detoxification function of the liver. I have a question. What is detoxification function determined? Your answer should be hippuric acid synthesis test. So the liver removes benzoic acid administered as sodium benzoate. It combines with amino acid glycine to form hippuric acid. The amount of hippuric acid excreted in urine is in a fixed time is determined. Interpretation: so normally at least 3 grams of hippuric acid expressed as benzoic acid or 3.5 grams of sodium benzoate should be excreted in health. Smaller amounts are found when there is either acute or chronic liver disease damage or in any diseases. Amounts lower than 1 gram may be excreted by patients with infectious hepatitis. So IV hippuric acid test. The indications: when there is impairment of absorption due to absorption defects. So interpretation: in normal health, hippuric acid equivalent to at least 0.85 grams of sodium benzoate or 0.7 grams of benzoic acid should be excreted in 1 hour. Excretion of smaller amounts than above indicate the presence of liver damage. So clear cut guidelines there. The test thus depends on 2 factors: the ability of liver cells to produce and provide sufficient glycine, the capacity of liver cells to conjugate it with the benzoic acid. So conjugation process there. For reliable result, renal function test must be normal. So sometimes you need correlation of LFT with the renal function tests. Both oral and IV forms of the hippuric acid test are in use. So tests based on the excretory functions, that is bromsulfathiline test, the retention test. What is the principle here? The ability of the liver to excrete certain dyes. What are those dyes? These bromsulfathiline. So removal of this BSP by the liver involves conjugation of the dye as a mercaptide with the cysteine component of the glutathione. The reaction of conjugation of BSP with the glutathione is rate limiting. Thus it excretes So thus it exerts a controlling influence on the rate of removal of the dye. So removal of this particular BSP is very much important here. Interpretation. In normal healthy individuals, how is it interpreted? Not more than 5% of the dye should remain in the blood at the end of 45 minutes. Okay? At the end of 45 minutes. In parenchymatous liver diseases, removal proceeds more slowly. So diffuse parenchymal liver disease, so removal is slow. In advanced cirrhosis, 50% of the dye is retained in 45-minute sample. So retention of 50% here. Contraindications. Since the dye is removed in bile after conjugation, this test can only be used in cases in which there is no obstruction to the flow of bile. Clinical significance. It is useful index of liver damage, particularly when the damage is diffuse and extensive. The test is most useful in liver cell damage without jaundice in cases of cirrhotic liver, chronic hepatitis. Then indocyanin green tests, the rose Bengal dye test. Now, so these tests were earlier used very much efficiently. So nowadays they are done less because of hypersensitivity reactions. Formation of prothrombin by liver, important test. So liver is responsible for synthesis of clotting factors 279 and conversion of inactive pre-prothrombin to prothrombin. So prothrombin time is the time, that is the PT. So invariably most of the doctors write this preoperatively just for screening test too, not only in liver diseases. So if they have any doubt in BTCT, bleeding time, clotting time, or if they suspect any liver disease, so usually the physicians or the practicing doctor writes for a lab investigation of PT. So PT normal value 10 to 16 seconds. So is the time required for clotting to take place in citrated plasma to which optimum amount of thromboplastin and calcium is added. So interpretation, in parenchymatous liver diseases, depending on the liver cell damage, PT may be increased from 22 to as much as 150 seconds. In obstructive jaundice, due to absence of bile salts, there is defective absorption of vitamin K, hence PT is increased. See, important one here, the relation between PT, vitamin K and the liver. Wherein in obstructive jaundice what happens? Due to absence of bile salts, there is defective absorption of vitamin K. So vitamin K is not absorbed properly. Hence, prothrombin time is increased. So basically this is due to the diffuse parenchymal liver disease. So drawbacks of PT. As PT is increased both in obstructive jaundice and diseases of liver cell damage, that is parenchymal disease, PT cannot be used to differentiate between them. So differential cannot be provided here. So however, if adequate vitamin K is administered parenterally, then PT returns rapidly to normal in uncomplicated obstructive jaundice. So it returns back to normalcy in cases of uncomplicated obstructive jaundice after administration of vitamin K. Whereas in liver cell damage, the response is less marked. So basically, this is how you differentiate after administration of vitamin K. So test based on amino acid catabolism. So determination of blood ammonia. The nitrogen part of amino acid is converted to ammonia in the liver mainly by transamination and deamination, and then is converted to urea in the liver. So the normal range 19 to 60 micrograms per deciliter of this particular ammonia. So this ammonia tolerance test, so should be also aware of this particular thing. An ammonia tolerance test has been devised to test the ability of the liver to deal with ammonia coming to it from intestine. Interpretation, in normal persons little increase is found. So blood ammonia levels remaining within the normal range. In advanced cirrhotic liver, what happens to this ammonia level? Marked rise to twice the initial level. So that is very significant here. Considerable increase seen when there is collateral circulation and in patients who have a portocaval anastomosis. So this is again drug based on drug metabolism, that is monoethyl glycine xylidine. The principle, again, the capacity of the liver to metabolize certain drugs is used as a measure to hepatic function. So how efficient is your liver or the patient's liver to metabolize these drugs? So determines its basic activity or the liver function ability. So again, so this is how you assess this drug. So this MEGX is determined in the serum by use of automated fluorescence polarization immunoassay. The interpretation, how is the interpretation here? In patients with cirrhosis of liver, the increase of MEGX concentration in serum is much less marked and decreased value is dependent on disease severity. So antipyrine breath test, what is the principle here? So antipyrine like lidocaine is also metabolized by cytochrome P450. So when given orally, it is absorbed from intestine completely, not bound to plasma proteins and metabolized by liver only. So interpretation, normal subjects excrete 5 to 8% of the administered dose in 2 hours. Patients with hepatitis or cirrhosis excrete only 3%. So that is how you interpret this. So determination of serum enzyme activity. So these are very important one, AST level or SGOT, ALT alanine aminotransferase or SGPT. So heart muscles are richer in SGOT whereas liver contains both but more of SGPT. So you should be aware of this. So any SGOT variation in levels also indicates heart disease also, not only the liver one. So more specific to liver could be SGPT relatively. Normal values, SGOT 5 to 40 units per liter, SGPT 5 to 40 units per liter. So normal AST ALT ratio 0.7 to 1.4. So methods of determination of serum transaminases, the kinetic method, the DNP or the calorimetric method, the Reitman and Frankel method, the Sachs and Moore method using disodium salts. Now the interpretation of this, increase in both transaminases are found in liver diseases with SGPT much higher than SGOT. So liver function test, SGPT, SGOT fluctuation, raise in the levels. Which is more raised? Specifically the SGPT is more related to liver ailment, liver disease than the SGOT. SGOT mostly associated with liver and heart diseases. Their determination is of limited value in differential diagnosis of jaundice because of considerable overlapping. Their determination is of extreme use in assessing the severity and prognosis of parenchymal liver disease. In acute infectious hepatitis and serum hepatitis values around thousands are seen. See, huge levels, huge increase in these levels of this SGOT and SGPT in thousands. So determination of serum transaminases is the most sensitive diagnostic index which is used as screening test in the outbreak of infectious hepatitis. The increase can be seen in prodromal stage when jaundice has not appeared clinically. In obstructive jaundice, levels increases but do not exceed 200 to 300 international units per liter. Very high levels, that is in thousands, are also obtained in cases of toxic hepatitis due to CCl4 poisoning and viral hepatitis. Drug hepatitis could be in the form of chlorpromazine. So AST-ALT ratio greater than 2 or 2:1 ratio is suggestive. So basically it's high value suggestive of alcoholic liver disease. Enzymes that reflect cholestasis. So important one. Even Viva they can ask you this. What are the enzymes that reflect cholestasis? So these are the ones. The alkaline phosphatases, nucleotidases, gamma glutamyl transpeptidase. Serum alkaline phosphatase, commonly done tests by the physicians in assessment of liver function tests. The normal value 3 to 13 Ka units per 100 ml. So it is found in a number of organs, most plentiful in bones and liver. So any disease of the liver and bones, alkaline phosphatase levels are increased. Always remember that. So both the organs may be involved here. So you have to differentiate where actually their elevation is related to in case of the patients. Higher values are also obtained in space occupying lesions of the liver. Example, abscess, primary carcinoma, that is HCC, metastatic carcinomas, infiltrative lesions like lymphoma, granuloma, amyloidosis. So serum alkaline phosphatase is found normal in hemolytic jaundice. High with low aminotransferase activity is usually seen in cholestasis, and low levels with high aminotransferase activity occurs in non-cholestatic jaundice. See this correlation. This is very much important in arriving at few diagnosis of the liver or any clinical diagnosis. So correlations are done here of these particular alkaline phosphatase levels with the aminotransferase levels. Gamma glutamyl transpeptidase, the normal level 5 to 40 units per liter. The activity of this microsomal enzyme has been found to increase in most of the hepatobiliary disease. So due to enzymes, so the tissue distribution, the specificity of a high value, so is very low here. The specificity of high values. An elevated levels of this glutamyl transpeptidase implies that an elevated alkaline phosphatase is of hepatic origin. So that is the inference here. It may be useful in screening for alcohol abuse, important test that you do in alcoholics. Sudden increase in gamma glutamyl transpeptidase in chronic alcoholics suggests recent bout of drinking of alcohols. In case drinking of alcohol in alcoholics, some words are missing there. Then serum 5 nucleotidase, the normal level 2 to 17 international units per liter. Interpretation, so it is raised along with serum alkaline phosphatase in diseases of liver and biliary tract in a roughly parallel manner. It is highest in post-hepatic obstructive jaundice, frequently over 100 units. It has added advantage over serum alkaline phosphatase in that enzyme is not affected in bone diseases. Smaller increases are found in hepatic jaundice, example in infectious hepatitis. Immunological tests, so important one. So this is also a part of the liver function test that you should be aware of. The hepatitis A anti-HAV IgM tests. So the antibodies tests are being done against these viral bodies. The hepatitis B, the dangerous one, the acute and chronic one, HBsAg, and anti-HBc immunoglobulin YAM. The chronic HBsAg and HBeAg and anti-HBs. Hepatitis C, hepatitis D, hepatitis E. So all these antibody tests are being performed here. So the antigen and antibody tests, it's anti-HCV, HBsAg, anti-HDV, anti-HEV. Autoimmune hepatitis, that is ANA, anti-nuclear antibodies, SMA, smooth muscle antibodies, elevated IgG levels. So in primary biliary cirrhosis, Mitochondrial antibody elevated IgM levels. So in sclerosing cholangitis, ANCA test is done, anti-neutrophil cytoplasmic antibody. So they might ask you in Viva also just about the long form of ANCA, or a 3 marks question. ANCA is important. Remember that. So this ANCA is increased in sclerosing cholangitis. So what are other diagnostic tests? Ultrasonography. Advantages. Ultrasonography is the first diagnostic test to be used in patients whose liver test suggests cholestasis. It helps in identifying presence of a dilated intrahepatic, extrahepatic biliary tree and gallstones. So correlative diagnosis. So not only the in basic biochemistry, but also the ultrasonography is important here. It shows space occupying lesions. So a few points on ultrasonography in the answer of LFT is also important here. So it helps direct percutaneous biopsies. So that is biopsy, USG guided biopsy, or the USG guided cytology, aphenesis can be done. Ultrasound with Doppler imaging can detect the patency. So basically this particular patency of the portal vein, hepatic artery, hepatic veins also can be determined here. So this is the first test in case of Budd-Chiari syndromes. So percutaneous liver biopsy, very important one in the diagnosis of any liver parenchymal disease, the gold standard test. Percutaneous biopsy of the liver is a safe procedure that can be easily performed at the bedside with local anesthesia. So nowadays, this test is not so easy to perform. Usually they even take into the OTs, minor OTs for this particular test. Liver biopsies of proven value in the following situations, that is HCC, prolonged hepatitis, hepatomegaly, hepatic filling defects, fever of unknown origin, staging of malignant lymphomas. So liver biopsy is most accurate in disorders causing diffuse changes. Liver biopsy should not be initial procedure, okay, in the diagnosis of cholestasis. The biliary tree should first be assessed for signs of obstruction. Contraindications: significant ascites, prolonged INR, prolonged prothrombin times. So those could be the relative contraindications. So even the biopsies can be performed via the transjugular approach. So you should be aware of this. So what is the limitations of LFT? Lack of sensitivity, that is maybe normal in some liver diseases. Lack of specificity, that is maybe abnormal in non-liver disorders. So these are the basic limitations of liver function tests. So basic summary, several biochemical tests are useful in the evaluation and management of patients with hepatic dysfunction. These tests can be used to detect the presence of liver disease, distinguish among different types of liver disorders, gauge the extent of known liver damage, and follow the response to treatment. So this is basically the normal chart that you should put if asked in 5 marks. If 5 marks question is asked on this particular topic, your answer should contain such charts, the tables. So pre-hepatic or the hemolytic one, the hepatic assessment, the post-hepatic or obstructive one, how are these particular tests displayed? The blood conjugated bilirubin, the conjugated bilirubin values, the urine bile salt values, where all it's absent, which all diseases which are present, Fauchett's test, Ehrlich's test. So this table is very important here. It impresses the examiner if put in your answer sheets. Serum enzymes, very important one. See there how they are being normal here in the first column and then deranged. So this table is very important. So this concludes our topic of liver function tests. So Dr. Rajesh Patil here signing off for you. Thank you.